All right. Welcome, everybody. Welcome to another Compliance Capers. My name is Sonal Patel with SP Collaborative, and here's my very good friend, Betty Hovey with CHCS Consulting. So, everybody, welcome to March Madness. Here we go. It is our last episode this month. I can't believe the month went by so very quickly with so much rich resources. I hope you all have for the OIG work plan. So now today in our final episode for the month, I really wanted to talk about something near and dear to both of us over the years with the amount of work we've done for providers regarding critical care services. Kind of sad, in my opinion, that these guys are in the spotlight as well, right? The critical care types of services, these specific evaluation and management codes. Yes, they are in fact grouped in that section of our CPT code book, evaluation and management, right? The report that we're talking about is only specific to two CPT codes. So they're not talking about the baby who might be involved in the NICU. So there's no NICU types of codes. It's just the 99291 and then the add-on code 99292. So even though we were talking offline a moment ago, but we can talk about it now, there can still be a lot of damage that's done with just two CPT codes, right? If we're not compliant in our coding and if we're not compliant in our documentation style of practices. So welcome, Betty. I wanted to get your quick thoughts on this, rather unique type of service. It's necessary for patients that are really in like a dire straits situation, right? In the hospital inpatient space. So it's critical care.
Yeah.
And yeah.
Yeah, I think traditionally when I used to teach coding classes, and now when I talk with clients and physicians and their coders and people in their offices, I think the number one issue that I continue to see with critical care is just like when we've been talking before about other coding, when they try to tie like a diagnosis in with a specific level for ENUM, like, oh, if they have COPD, it's always a level 4 office visit, or if they have,
Right.
and with critical care, I would always hear, well, they're in the critical care unit, or, well, they just had a heart attack. And I'm like, okay, but what are you seeing them for?
Right.
Just because the patient's in the critical care unit doesn't mean that your physician, provider is giving that patient critical care that day. So it really takes a specific eye to looking at the documentation on that daily basis to look for changes. Patients can be critical. They can get better and look like they're, going to be transferred to a regular floor, and then something happens and they're critical again. So you can have them back and forth going with these codes while they're on an inpatient stay for various reasons. But it's specifically looking at what your provider did for that patient at that visit on that day. So that's what you have to remember. It's not about their diagnosis specifically. It's not about their place in the hospital specifically, because critical care can happen anywhere. So just because they're there doesn't mean that's what y'all did.
That's right. Yeah. See, we both come with so many opinions, right, in this particular space because, yeah, we've heard it all. And providers need to remember that their critical care services can literally happen anywhere. You do not have to suddenly transfer the patient to the CCU for it to be considered critical care, right? It's that documentation that you, again, matriculate from the gray matter that I keep saying on compliance capers after compliance capers. It needs to be released into the EMR to actually support the 99291, right, for the critical care code. So yeah, let me pull up the report here, the general OIG work plan summary. And then I will tell you guys the greater report number here is A-03-20-00002 for Medicare Critical Care Services Provider Compliance Audit. And they do disclose the name of the clinic here, and it is Leahy Clinic, Inc. Now, in general, when you read the first part of this report, it's going to say why the OIG did this audit, right? Medicare paid approximately $2.4 billion for critical care services provided to Medicare patients nationwide from January 1st, 2017 through March 31st, 2019. And that is their audit period. And so during the 2018 Medicare improper payment error rate, they found for critical care services was 19.7%, or about $198 million. So, a lot of money involved, a lot of, overpayments that they could be talking about here, right? As the various other reports that they're going to close out on this greater OIG work plan program for the year 2024. But this particular report that I've pulled here, this report on that clinic that I disclosed, it is located in the state of Massachusetts. So like we talked about earlier, there was a report that disclosed it only affected one particular practice. It was the ophthalmology practice that I believe we talked about. No, it was, yes.
Yes.
Yes, it was the ophthalmology one, and it was in the state of Florida. So, yeah. So we tried our best this entire month to provide you with snippets of reports, right? That either vast, they go across the entire country. There are, multiple MACs that are involved, or these reports can hone in on specific entities like they do in this case for the critical care services, right? Where their findings were direct and specific to this entity, and, where they sort of went sideways in terms of documentation that they pulled, they randomly sampled, etc., right? But once their team got a closer look at the actual records for critical care services, they identified that documentation did not support the actual either time elements for the critical care, which means, right, per CPT definition for the first code, that 99291 code, you have to meet the critical care time for 30 to 74 minutes.
Right.
You have to. If you have any time that's less than 30 minutes, you should be reporting another evaluation and management CPT code, not for critical care, because that has to start at 30 minutes. So they really did a great comprehensive job as usual as they go through their multiple findings for this particular clinic in Massachusetts.
Yep. Yeah, what I found interesting is the on page 5 of this report, if y'all are going to look at the report, and we suggest you do, that,
Yes.
They pulled this clinic because they looked at 92 critical care services for this clinic after they data mined out of that large pool and said, okay, where are the big ones at that, could have a lot of issues? And this clinic got pulled out. Out of the 92 records that they looked at, only 36 of the records complied with the guidelines and should have been paid as they were reported. So 39% was their compliant rate,
Wow.
which means that 56 of the services, or 61%, did not comply. So that's
Yikes.
pretty big. I mean, if
That's a
we did,
large figure.
yeah, if we did an audit and somebody got 61%, we'd have like big educational plans and meetings and everything else set up,
Yes.
and probably not let them touch their own coding. It would be like, no, somebody else needs to do this for a while till we get you on the right track. But that's pretty, that's pretty bad where they were sitting. And out of that 61%, they said that 73% of that should have been billed as a subsequent hospital visit. So in other words, 73% of what was incorrect was services that did not meet the criteria to be able to be reported as critical care. So they should have been subsequent hospital services. And then 27%, according to the OIG, didn't meet the requirements for payment as critical care or any other E&M service. And from reading through some of the report, we were discussing that, some of those are because the patient was actually in the global post-op period, and the surgeons were billing for critical care services in the post-op period, when from the OIG's review, they should have been global follow-up surgical visits, and which would have rendered them unreportable or bundled into the global surgery package. So, that's kind of what they were looking at in here. But it was interesting to me. And again, we were talking too, we're hitting back on page 6 of the report. They really hammered on policies and procedures. And I think that's definitely something that, we said we wanted to discuss. So at the top there, under the big graph on page 6, it talks about the fact that the errors occurred because Leahy did not have adequate policies and procedures to ensure that physicians correctly documented in the patient's medical record and identified critical care services that met Medicare requirements, and that coders made correct determinations for critical care services that met Medicare requirements. So they didn't have policies in place for either one of those. And it kind of digs further into it on another page, but I know that's something we wanted to definitely throw out there.
That's right. And that's what we stress, right? Is that the OIG likes to see practices develop their own internal policies, right? And they clearly identified in this case that this clinic in Massachusetts did not have one, right? And so that is why my good friend here and I always stress to our own providers that it's best practice to implement your own policies for your service lines. It's simply imperative. And the OIG, really, really took it to heart in these 30 some pages on this report again and again, right? Hammering the name of this clinic again and again on what they were deficient on. And how you can take a look at it. But, if they happen to have a policy in place, things might have gone a different way, right? They might have gone a different way. So,
well, just like as we were saying, having these policies and procedures in place as part of your compliance program, once again, audits should be a regular part of that. And if these things would have been audited, then it would have gotten caught. And because on page 12 of this report, they talk about their process, that actually this clinic did have a process for critical care. So it's not that they were just blatantly ignoring it and slapping it on stuff. They actually did have a process in place. And it's under the section that's called Effect and Cause of Improper Billing of Critical Care Services. So in the third paragraph there on the page, it says, they had a process. So a physician treated the patient, documented the critical care service in the record, then the clinic's instructions state that the medical record should include, and they said what everything it should state in there: the treatment, the physician's total critical care time, and then the physician would select the critical care placeholder code. So once they chose it, it routed it over to a coder's work queue so that a coder could perform a documentation review. Sounds good so far. The coder reviews the medical record to determine whether the documentation meets requirements for critical care. Specifically, their review included assessing the patient's condition, the physician's interventions, and the complexity of decision-making to treat the patient's illness, and of course, the time, because we all know that's a factor for 992, 91, and 92 is the time. The coder assigned the appropriate CPT code based on that review, but there's no internal quality control process to determine whether that coding process is accurate. That's where the problem came.
That's where the problem came. No auditing of their processes, right? No external audits of what the coders were choosing and doing with that documentation. Wow. So yeah, this particular report spells it out, unlike the others that we have reviewed that you all should have access to by now. But they do things uniquely to each specific entity, if there happens to be an entity involved, and in this case there is one, right? And so they really take that extra time to help all of us in this education space, in the compliance space, right? Understand how things can be done better. And so, like you outlined, they had some pretty good processes in place, but they missed that that little extra step of you have to do that external auditing of your coding, team, and that just was not.
I think it would also be interesting to see what their training and education programs were for those coders. I mean, would they take any coder and put them into the critical care space and let them do it? Or did they have to go through some extra documentation training and auditing training for this kind of stuff? Or, it doesn't really spell that piece out in here, but my thinking is it probably wasn't either being done or it wasn't robust enough. If this is actually what's happening, then definitely the people that are allowing the codes to go through after they're reviewing them, if they're actually reviewing them and letting them go, then they don't understand critical care.
Right. Exactly. And as you and I know, and as you guys can read throughout this report, the critical care components themselves are complex, right? You have to be able to make sure that your documentation, highlights all of those key requirements to support the critical care service. So, it is rather complex. And so if the coding team is not as robust in receiving their education materials. And let's not forget, in today's landscape, right? This is from the past, thank goodness. But in today's new 2021 landscape, things have changed once again for the critical care coding, right? And supportive documentation. So it's just completely fascinating how the OIG can come in and make their recommendations after their findings, right? And in this case, how about all of those refunds, which of course they've identified once again, like they always do, the overpayment amounts based on their findings for all of their buckets of service lines.
Yeah, but in this case, also it because of the amount and the fact that it was 61% or 61%. Whatever, they also are saying that they need to go back even further. And this came up with that ophthalmology case when we were talking about it, that when they realized they weren't supposed to get paid anesthesia with the intravitreal injections, they stopped. Right. But they just stopped. You did the other money, you were getting paid when you weren't supposed to. So in this report, that was something that the OIG did call out. And it's on page 13 of the report under their recommendations was that based on the results of the audit, that they think reasonable diligence needs to be exercised, and they have to do that 6-year look back. And they agreed. So that's the other point to this, where, you know, when you find those things, so doing those audits regularly and looking at stuff will prevent this kind of thing from happening. You know, I'd rather get paid a little bit less today than 7-8 years from now be told, we need you to go look back for the past 6 years and pay us everything at once that you got overpaid. You know, so those little bits start adding up, and now you got this huge amount you're supposed to be paying back. And now you're talking about payments and interest and all that kind of stuff. Whereas if you're doing it correctly in the first place, I'd rather be paid right the first time than have to go back and deal with all that. Plus, you know, paying somebody to do those things. You have to get a statistician. Ooh, I did it.
You said it. You said it.
To look at those things and to say what see, now I said that to myself. I can't do the second part. This
statistical
valid
report.
Sample.
Valid sample. Statistical valid sample.
You have to hire somebody to do that for you.
You do.
You know, and that can get a little pricey, and that involves a whole lot. I don't do that. When I do these things with attorneys, they always have me get in touch with that person, or they get in touch with, because I'm like, yeah, that's the, you know, mathy stuff that I don't like to play with. So they do that. But, you know, that you have to get somebody to do that. Then somebody has to look at those records to determine how much you actually should be paying back. It's, you know, you're talking about a whole big process now. This clinic has opened itself up to because of not auditing and not being on top of what's going on to make sure that they're staying in compliance and everybody's doing the right thing. So it's going to cost them a whole lot more than just that payback amount, right?
Exactly right. And yeah, you are like a little clairvoyant with your crystal ball in Florida, right? Because you said it spot on for the ophthalmology one, right? Where you were like, the OIG sort of missed something here. How about looking back for the past, right? That we talked about. But here they are for critical care addressing it spot on, that no, we need you to look back right now. And we're going to put it in our recommendation, right? So
absolutely and true. The look back, the time, remember? The time for that, when you have to do that, it's not like you can do it for 6-7 months and we'll get back to you.
Yeah.
60 days.
60 days, people. It's fast, rapid fast. And again, like we say on this compliance capers all the time, for these types of complicated procedures, it's best recommendation to get a trusted healthcare attorney to help you navigate the way, you know, because the steps are complicated. There are deadlines to meet, and they understand how to talk to the government very, very well. They do it all the time. Whereas you yourself as a provider, hopefully you've never had to, right? But these attorneys know how to do that and know how to help you navigate the complex ways, the complex manners in which you have to get things back to the government timely. So yeah, it's unfortunate that the findings and recommendations for this report came out this way, but this particular clinic, again, did agree to most of the findings, and they wanted to go ahead and appeal on some of the things that they wanted to appeal on. But as you go through the weeds of this report, the OIG has stated they never actually provided any other supplemental documentation to appeal anything with. So they stand on their findings that they want everything back because the clinic didn't actually send anything new in terms of documentation to support the critical care services, right? So that's kind of a wash So the
Yeah.
clinic went through all of these extra steps to say they wanted to appeal, but then they never actually produced any supportive information. So I thought that to be a very interesting tidbit in this particular case as well.
Yeah, maybe they got, somebody, an external, consultant, auditor to kind of take a look at some of this stuff. And,
Mhm.
we're like,
And they realized, yeah, actually, sir, at the clinic,
yeah,
you don't have anything to stand on,
I
right?
mean, we don't know, but,
We don't know. We're
yeah.
being
And it's
hypothetical
also,
here.
there also was some, path stuff, teaching hospital stuff, that was wrapped in
Yes.
here. So that's something else that if y'all are involved with teaching hospital guidelines, to make sure you're kind of reading through that kind of stuff too, because they do discuss the GC modifier and things like that in here, with, with the services when they look at some of the records. And they said that the, attending physician was like doing rounds, and so the residents were in
Mhm.
there and things like that. So they do touch on some path stuff too. So that could be something that if y'all work at a teaching hospital, that you may want to kind of check this out, even if your department isn't doing critical care. If you are billing for attending physician services while they are supervising residents, you may want to take a look at those pieces to see how they talked about, what they thought were some of the issues with the path guidelines, whether they were or were not being followed. So that's just an extra little kind of thing thrown in here that for y'all, for those of y'all that work at teaching hospitals, you may want to take a look at for that reason.
Exactly. That's a great point as well. I forgot that. Yeah, that was actually touched on in this report as well in a couple of cases. So it's definitely good for our audience if you happen to work for those types of facilities to go ahead and read this report, to make sure that your facility is doing things correctly, and you understand the modifier GC, and you understand how to use these particular codes in conjunction with your documentation to make sure that these claims are being appropriately paid the first time. So, yeah.
Yeah, and they use independent medical review contractors, with
Yes.
what the OIG used when they were doing these. When the clinic came back and said, "Hey,
Mhm.
we take umbrage to some of the claims that y'all say don't
Mhm.
pass muster."
Right.
So they did give a couple examples back, and that the clinic had disagreed to. And so they sent them to some independent contractors to kind of review these two cases that they did share back. And, just as an example, I know we wanted to touch on real quickly,
Please.
from a specificity standpoint with what they may be looking for, is that one of the examples, the clinic had sent back and said, see, this does reach critical care definitions to bill because the patient had hypoglycemia with seizures, and they had a dextrose infusion, and monitoring carefully for their glycemia. But when the independent review contractor looked at the services and looked at the medical record stated that in the emergency room, the patient was stabilized. And then the patient was alert, oriented when talking, denied critical care service was provided, only required antihypertensive medications for their hypertension, and their lab work was normal. There was no EKG changes or evidence of pneumonia or respiratory failure. So just because the physician at the end of a note like that, where everything's normal, they're talking to me, they look good, we're just going to continue their hypertension medications, all their labs are normal, their EKGs are normal, and at the end of that, the physician says, I provided 45 minutes of critical care service, doesn't
Right.
make that critical care.
No.
So, when you look at the record, if you're saying normal, within normal limits, The patient is comfortable. The patient is sitting up in bed. The patient is visiting with their family. Things like this that we see when we look at these critical care notes.
Right.
That's going to call the fact that that is critical care into question by anybody else that's looking at that record.
Absolutely.
But just because they make the magic statement doesn't always mean that that's what it is. That's my point.
That's beautiful. I'm glad you plucked that example out, because that's exactly where we needed that coding team to go back and review that statement at the bottom of that particular chart note, right? Because someone on that coding team should have, in my opinion, put a query back to that critical care doc, right?
Yeah.
That perhaps you need to make a amendment to that statement, because look, the patient has clearly been doing better and better and better as the days progressed during his or her inpatient stay, right? Your previous documentation supports the fact that the patient was in fact stabilizing. So can we do away with that statement that you made for the critical care, right? So those types of clear and evident documentation examples that the OIG provides are wonderful to take back to your own practices to help your doctors see, oh, I can't use a statement like that if I know the patient throughout the days inpatient stay has been improving. There is no way that I could qualify any type of a service as critical care if my previous documentation is clearly showing my patient is stabilizing, is improving, his labs look great. Like, that is not a critical care patient.
Just because they say it doesn't make it so, and that's a perfect one for that. My mama is saying that I've told you before, that just because the cat has kittens in the oven doesn't make them biscuits. Just saying it doesn't make it so. It's got to follow up with it.
That's right. That's absolutely spot on. And I love that analogy from your mama. It's so cute.
She had a million of them. So,
oh my goodness, adorable. But yeah, that's a great example, right? Because just because the doctor says so, and again, it's that reimbursement is going to be higher, right? It is a critical care service. So we have to be really mindful. Our coding teams have to be really mindful on going back to review that documentation to make sure if you need to conduct a query, make sure you do so.
Yeah, they're looking for the high dollar amount things. Critical care, if you look at E&M codes, that's where the big dollars are for E&M, right?
Exactly. Exactly right. Did you have another example from the OIG that they plucked that could help the audience?
They had another one that was for a patient that had a myocardial infarction. And
that sounds serious. Okay.
Yeah. It says critical care services were necessary because they had unstable VTAC, ventricular tachycardia, profound hypotension, and again, it required careful monitoring and treatment with titration of vasoactive medications and management of tachycardia post-operatively. But the independent review contractor's review of the service stated that, again, the records said the patient's condition was stabilized the day before the date of the denied critical care services. So on like Monday, they said they're stable, but on Tuesday, they're still reporting critical care. And on the date of the denied critical care services, the patient was alert and pleasant.
Yeah.
So, and the report too, if y'all are looking at it, they do give a couple more just throughout here from the OIG when they were looking at them. So if you look at pages 9 in the report, pages 10 and pages 11, they also give more examples that are a little bit longer in length. So if you're looking for examples to show your docs and your coders and your, if you're looking for educational kind of stuff, you can kind of pull some of those examples and say, see, this is where the OIG is saying this is not good. This does not meet critical care. And here's why. So that's good. That's, again, a nugget. There's your nugget from this report, is to give you those examples that are coming from the OIG that you can say, see, they said no.
Right. Exactly. That's a great tip, right? Is that these documents that are publicly available once they're closed out, like this one is, these are gems. These are hidden with multiple gems for our providers to understand why to have your documentation written in this fashion does not support the definition of the CPT code for our 99291 or 292, right? These are great examples of what not to do. They literally give us multiple examples throughout this report. So absolutely true. These reports this entire month with us, I think, has been fantastic, because these reports that we're showing you are full of these gems.
You pulled some really good ones.
Yeah, thank you. I'm glad. I hope the audience enjoys, because we've tried to provide this entire month with, multiple specialties, multiple service lines, because I know our audience here is vast. Healthcare professionals, vast. Our doctors, vast, right? But there is so much at stake when the OIG is involved, right? And from, as we've learned, month to month, they put a lot on their plates and they have a lot to do. And it takes about a year or so to fully close out these reports completely in the overall program. So they still have much more work to do for psychotherapy. They have much more work to do for ophthalmology with those eye injections. They have much more work to do still on the spinal facet joint injections. And they still have more work to do on this critical care. So, bravo to these reports that we can use every day, to put into our toolboxes, right? To help not only ourselves do better at our jobs, but we can help our providers as well, because they are the ones who have to perform the documentation, right? And they have to do it very, very well to help support all of those CMS 1500 claim forms that they're pushing out to the CMS. Yep. So, yeah. I hope today's last session in the month of March for critical care has been meaningful to the audience. I know I found great meaning in this report. There's lots I can take away to my providers in this particular specialty. I know they have lots to gain from this report. So I know I love this one.
Yeah, it's a good one.
Yeah. So anyways, my friend, thank you so much for another fantastic Compliance Capers today. I'm so glad we provided this much information on the OIG work plan this entire month of March.
Yeah.
So I can't wait to see what you have in store for all of us during the month of April. I know I'm excited. If you wanted to give a teaser, I'll leave it up to you.
April showers, so we're going to take a look at self-disclosures and some different cases where places have done audits and have been looking at things and, have noticed kind of an oops when they were doing their procedures. So instead of waiting for someone to find it, they self-disclose, and there is a specific route to go through when you are doing that. And we'll talk about that and how healthcare attorneys can always be your friends, as we always are talking about those people. And, some of the self-disclosures that have been made and things people have found, so that, again, if you find something in your practice or you do something in your practice and you hear one of these things on Compliance Capers, you might be like, we need to check that, so we try to bring things that are hit like bigger audiences and bigger specialties and practices, things that a lot of people are doing. But we'll, diverse off into some specialty, super specialty things if they're really interesting. But it just gives you something to chew on and something to look at. So yeah, we're going to look at self-disclosures.
I love it, Betty. That sounds fantastic. I'm so excited for next month. Yay. All right, my friend. Well, thank you so much. And thank you, everybody in the audience, for helping support our compliance capers. We love having our discussions with you each and every Friday. So can't wait to see you guys again next week.
Yes.
Thanks
Thanks,
so much.
Bye.
Bye.